It's clicker fear, okay? And now that I know it comes from Garrett, it's even more potent, so I keep hearing it. Startled response. Well, it's a pleasure being part of this organization, and I'm already learning a lot. Time for reflection, too, about sort of career and what my perspective has been. I guess I'm a sort of boarded partial kind of person. That's been the basis of my work. And I think like many of us in recovery who work in the field, even if we sort of try not to, I think our perspective does come from a personal place. And where I actually had, I believe, a transformation that has translated into over 30 years of recovery, it had to do with what happened to me at a particular time in my treatment experience, which was long. Spanned residential, and then you move into apartment, go to partial programming, and then I stayed in sober living for months, and that's what did it for me. I actually never, it was kind of before the time of the kind of partial, rather the professional health program monitoring that Dr. DuPont was talking about. So I had my stay in Georgia and then came up to Chicago, where I'm from, with a venture that was actually, in retrospect, a tremendous opportunity that never happened. It was the formation of a company called SAFE. This is back in '83, '84. And Ben Underwood, myself, a fellow named Roger Getz, who's passed away, some of you may know or remember, but headed up by Dr. Doug Talbot, who I had the pleasure of being mentored by and working with. And the idea was that we were going to take this second phase, this boarded partial phase of a 4-phase program, have graduates like myself of the program throughout the country work with these office-based centers that are both clinically effective and economically viable, and they don't cost the patient that much, and it seems like a lot happens in that setting. Unfortunately, the funding didn't come through. I stayed in Chicago, and I've been doing that over the years with different entities, but it is and remains one of the largest and oldest professional programs, certainly in the Midwest, but certainly in Illinois, one of the first in the U.S. Started right after Bill Farley started the Farley program, treated over 4,000 professionals. And again, comes out of the 4 phases of treatment, the Talbot model, I will call it, where you have a experience in residential, you step down to partial with independent living. Anyway, so 4 phases, including a transition into mirror image, where it's such an important phase where you're sort of half in treatment, half back in the community, preparing for your life at home and work. And then a 2-year aftercare, which is mandatory for all. We also do Fitness for Duty, was involved at Rush for years with the Isaac Ray Center and the forensic psychiatry, and we assess physicians and other healthcare professionals. It's a pretty supportive state board that I've worked with for years. A lot of interest for Chicago Medical Society now, kind of loose affiliations with our, PHP and the State Medical Society. I call this my shameless self-promoting slide, but my venture and passion for the last decade or so has been to try and organize treatment in a way that is consistent. So the patient gets this manual that I've worked on for 10 years when they come into the program. It's a curriculum, and that this guidebook facilitates communication between patients, staff and patients, provides a common language. The idea is because we really do learning theory in regards to what we do in treatment, assist patients in internalizing key concepts, improve self-awareness, And then there's a series of self-reports, including personality inventories. And I've been very fortunate to be able to work with Robert Cloninger, former chair of psychiatry at WashU, using his temperament character inventory. But we have several self-reports that we validated, and we're measuring outcomes. This is really a work in progress, because as we get the outcomes, and we look at not only abstinence rates, but perceived well-being, we can sort of change our approach based on those outcomes. Chicago is I think, a very robust place that needs high-end residential treatment. We've had this reputation as the city where people from Arizona, Florida, and other states come to market their inpatient programs, and we just have never had one. I think the possibilities for even treating obesity, compulsive eating patterns using the addiction model are very supported. A lot of ability for expansion. There's been a lot of talk about the emphasis on continuity over time, and sober living, I think, is a critical element. Of course, again, it's something I went through, so I'm partial to it, but I believe that when we can have people in sober living for extended periods, the outcomes improve. And of course, there's excellent academic partnership potential. So how am I doing?
Pretty good.
I'm going to sing a song I wrote in 1982. I left my brain in San Diego. Garrett, Kia C. So I don't really have much more to say. All right.